How can cognitive intervention go beyond standardized tests and worksheets to something that brings more meaning to our patients' lives? Find out more. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Welcome, everybody. Today, Lauren Schwabish is with me. She's a clinician with about 25 years of experience, including over 20 years of experience in a hospital setting. She recently transitioned to working in a private practice specializing in person-centered cognitive communication therapy for adults with neurogenic illness. Lauren, thanks for joining me today. Is there anything else before we get started that you would like for people to know about you?
Well, those are very excellent criteria. In addition to my clinical work, I do a lot of community health education. So there's some organizations that I partner with for folks who are living with MS and traumatic brain injury and aphasia. And so I do a lot of sort of like extra things on the side that I really enjoy. And it's kind of like hospital life where it's never the same day twice. Mm-hmm. But in the community, and I'm working with a whole different population than I had, for the majority of my career. So very rewarding, exciting work.
That's one of the things that I was going to mention. You sound very excited and very satisfied by the things that you're doing. Why is that? What is it specifically about your work that you enjoy or that you find particularly rewarding?
Yeah, I get that. Like, you're so bubbly, you're so passionate. And I think, honestly, it is this sort of like reinvention that I did 4 years ago. I never thought I would leave inpatient rehab. I loved hospital life. But, pandemic and things for many people just sort of, changed a little bit. So I decided to start my own practice. And I think what keeps me as motivated and excited is just the sense of, first of all, autonomy. I've never worked for myself, and now I do, and I run a business, and that sounds crazy to me still, but I like that aspect of it. But also really learning a whole new, I would say, like aspect of cognitive communication, being in the community. I am oftentimes a clinician seeing someone who, let's say, has just been diagnosed with mild cognitive impairment, or maybe I'm encountering someone who's been living with post-concussion syndrome for years, but never met an SLP. I'm encountering people who are in the community and they've sort of been through the rehab and now, they're coming to community-based care. And so it's really creative. It's really exciting because I think that for me, I'm always having to learn something new. I routinely will sort of go to the research and see what best practices are. And I really get to know my patients, my clients very well. I really think of it more like a partnership. Mm-hmm. I travel to people's homes. I see them at their offices. It's really just like a very, I would say, intimate level of conversation and communication. Mm-hmm. Some of the distractions of hospital life that the nurse is coming in to give meds or they're going off to get an x-ray, like none of that happens now. And so it's really rewarding. And I like sort of the connections I'm making with not just the clients, but their people, right? So spouses, partners, children, friends. I bring everybody into the fold in my sessions because communication and cognition affects everybody. So I think that's what makes me so happy about what I do.
It sounds like you have a high level of job satisfaction, which is what a lot of us are looking for. I think many of us are looking for that, and some of us don't have it. So I commend you and congratulate you, too, for being able to get that. That's amazing. There are some different directions that we could go with that based upon what we were talking about earlier. And the path I think that I would like to take has to do with what you talked about, you seeing people at work and seeing people in different settings. One of the reasons I perceive, at least, why sometimes therapists and patients, too, get so bored with cognitive therapy. I had someone within the last month, tell me, someone who knew that I was working with another SLP. They did a lot of cognitive therapy and they just got so bored with it. And I'm not saying that's everybody. And I'm not saying that even if you do cognitive therapy, one way or another, that you should be getting bored. But one of the things that's such a contrast is the enthusiasm that you bring to this. Now, am seeing some things that are different. I want to ask you, how much of that do you think has to do with the problem solving and seeing a patient in real life, seeing a patient within their life instead of just saying, okay, I did the R bands on this individual and they had a, XYZ score in this particular domain. And then finding page 99 of your workbook because that says this treats working memory or this treats whatever domain it was, because that can be, very, not to say that's never a thing that can help, but it seems to be very formulaic and may kind of stifle us intellectually at times. Does it have anything to do with that, or am I totally projecting here?
No, you're right on target. Yeah, I think one of the things, and maybe it comes with being a therapist for 25 years, where I just don't feel compelled to stick with that impairment-based model. I personally don't really like standardized testing. I don't like administering it. I don't think that it really helps to highlight a client's strengths. It's really good at picking up what's wrong. And it's really good at seeing how they do with something that you might have seen, 50 other patients do. So to that end, it's very useful. And it's not that I don't do testing. I certainly do. But the piece that I am going to again and again, and it really doesn't matter what the diagnosis is. It could be cognitive, it could be more language, it could be motor speech, are patient-reported outcome measures. And then using functional observation with things that are important to somebody. So maybe it's calling someone on the phone, or it's checking the sports scores, or it is going to work and trying to, handle an inbox and meetings. When you can watch people with a compassionate, non-judgmental view and think about what you're looking for, which I think is the piece that many clinicians can really kind of elevate their skills, is to see not only what does this, alternating attention or working memory impairment look like on this test I give, or this worksheet I administer, which again, workbooks, worksheets, toss them in the trash, not for me. But when I watch someone doing something, what do I see? How do I see, let's say some of these impairments show up? How do I build the person's knowledge of that? And then how do we work together to find a strategy? And that's really rewarding therapy because it's really starting from the person, right? The person you're working with, where they kind of point you in the right direction. And so that's where I would really say, of course, if you feel like there's a payer or a facility that is tasking you with testing, find whatever small subsets you feel are applicable to the individual, but definitely invest in the skills like active listening and observation and connecting, because essentially the goals write themselves. People will tell you what they're interested in, and then it's your job to kind of marry the two, right? What are you struggling with? What do you want to do? And how can I help you with that?
Yeah, I imagine that helps a lot with buy-in with patients. And I also bet that therapy becomes a lot more rewarding for you when you have the buy-in, when you feel like someone is your partner and you're not just banging on their door like, it's time for therapy today. And they're like trying to be real quiet because they don't want you to know that they're there. That
right, they don't want to see you. Yeah. Absolutely. I also think to that end, too, some of the metrics that can come from a patient-reported outcome measure or a self-anchored rating scale, which I love using. Again, it comes from research. It's not like I just made this up, but this idea of how do you help someone to sort of like scale, where they are now versus when they were at their lowest, what a small amount of improvement would look like, and then would they know when it's time to, finish therapy. Sometimes you may have someone who's telling you, I really have no idea what this diagnosis means. I've had people with concussion who've lived with it for years, but no one ever sat down to kind of explain that persistent post-concussion syndrome. That's building knowledge, right? And this patient rated herself at a 3 out of 10 when we met, and then we worked on strategies and met at cognitive education. And at the time of discharge, she was like, I think I'm like a 9.5. And I was like, wow, what an improvement. And it was a metric that made sense to her, right? Just like asking someone, maybe, how often are you participating in this meaningful activity? Or how confident do you feel with this activity? And when you can sort of pinpoint, sometimes people have their language feels pretty good to you and cognition looks pretty good. They drove to the office, they take care of their grandkids. And yet when you drill down on what the issue is and they're rating themselves as like a 1.5 out of 10, it's something else. So you're trying to think about, maybe it's your confidence, maybe it's your satisfaction, maybe you're feeling frustrated. So when you can really get to those, not just person-centered goals, but person-centered metrics, it's beautiful.
So it appears to take a very big picture approach for all of this. My mind went back to something that I don't do very much, or at least I haven't done in a long time, working with persons who stutter, right? The avoidance that they have. So when you're treating them, it's not just, well, let's make them more fluent, but let's get them out there talking and interacting. Or your individuals with aphasia. They don't want to go out to the store anymore because they're embarrassed to talk to people because they think that people perceive them to be unintelligent now, whereas they might just have an acquired language deficit. So they avoid those situations. And so it takes really a broader view to like, why does this matter and how is it impacting their everyday life, which to me is fantastic. I do know that some people are in situations where they have a lot of pressure, whether it's administratively or whether it's from insurance companies, to use or to be heavy, let's say, on standardized testing. Because I don't perceive you to be saying like, yeah, don't ever do a part of a standardized test or a standardized test because, to bill the CPT code for, oh dear me, I can't quote it off the top of my head, but if you're billing for a cognitive evaluation, they require there to be a standardized test. But it sounds like you're using it for a tool and understanding the purpose and not like, boom, you get everything from that. You get everything you need from it, right?
Yeah. And I would also say, like, for folks who are maybe feeling like I have to use a test, say, great, where's the source? Who's telling you have to use a test? Is it someone with knowledge of our field, right? Mm-hmm. Do you know what CMS says? CMS definitely values person-centered care. They have web pages about it, right? So go to the source and figure out what you want to be able to do. And then, of course, you have to look at billing and CPT codes. Financial compensation for our work is obviously a huge priority. But I'll tell you that 92523 cognitive communication code, if I'm doing something that's maybe informal, right? It's not standardized. I'm not administering a whole battery. I might be able to actually get everything done. And that's in my initial evaluation, and then use maybe my first visit to maybe drill down and work on a subtest of a formal test so that I'm not doing the whole battery just to do the whole battery, but I'm really saying, hey, you know what? I noticed the working memory was a real issue for you. Let's take a look at this test, figure out how you do on it. But let's also look at working memory in something maybe that you're doing every day. And let's have this conversation, because sometimes the test might be a great metric for that individual to show improvement. But I think the more person-centered you can be, always, that really takes a little bit of, I would say, flexibility.
Sure. And I guess what I was kind of looking at that more is finding, a lot of people might put this up as a barrier and are like, oh, I have to do standardized tests and then slam like a whole battery on somebody. Where I think you mentioned the CPT code 92523, which there's some nuance to this and ways that you can, one, potentially get around a standardized test. And please, I know hopefully you're not, don't take this as billing advice necessarily. Look into this. Don't come back and like, if you do something that I say, or that maybe I misarticulated, and then go back and like, you're not paying for this therapy, and then, come and hunt me down with a pitchfork, that wouldn't be cool. But so anyway, just that caveat out of the way. But from my understanding, there's some ways to get around this. So there is a CPT code for billing of like a cognitive evaluation, but there also 92523 is what we bill for speech and language. But I believe if you go on to dig a little deeper with what ASHA has out there, that if you are assessing language and you're assessing some other things, that you can include cognition as a component of that too. And you don't necessarily within that code have to have standardized measures for cognition. Again, please verify. That's how I understand it, at least. But then if you're doing the CPT code that's specifically for a cognitive evaluation, from what I understand it, they do require a standardized test. But so like whenever I was in outpatient therapy, I might do a very short standardized test, really prioritize the interview, because they are telling you the things that are bothering them. They're telling you how their issues with working memory are affecting them in everyday life in a way that the R-bands or the CLQT or whatever else can't tell you about. And so doesn't mean tests are bad, but use them for a purpose. That purpose is not going to be necessarily the most life-changing thing for the patient, in my opinion. All right. I hope I just didn't butcher what you said,
No,
but I'm kind of processing my thoughts.
I think ASHA has a nice description of some of the codes that can help you figure out like what you can do, what you can't do. I think if we look at what is best for the patient, you said it right. It is prioritizing that interview. If you are going to do testing, again, It's absolutely valuable in many situations. Being able to manage someone's expectations, right? So saying, you know what, I don't really, it doesn't, this, all of this testing is only for us to figure out maybe what strategies you're using and you're not aware of them, or what are areas of difficulty that I can help you with. But really making sure that you're talking to them before the test and after the test. You know, some people really, you need to establish that connection. You need to make them feel safe and secure. You don't want to start out the gate with something that they're going to just fail on, because then you are behind the eight ball and you've got to try to figure out, well, how am I going to get this person to want to do therapy with me? Because their only experience with you was in an office and you just basically showed them all the things that they can't do. Well, of course they don't feel like they know what's going on. So a lot of it is about our communication really shaping that experience.
And that's very ironic because they're coming to you for help because they want to feel better and they want to communicate better. And then so to just have all the things highlighted that they're not good at is probably pretty like against the purpose, right? That they came into.
Yes.
Actually, let me throw a quick story out there about a patient I had recently. I'm going to throw myself under the bus. This was a patient. She had a brain hemorrhage. I forget which came first. She had a fall. I don't know if the hemorrhage caused the fall or that she fell and hit her head in hemorrhage. But whatever it is, she had a brain injury, right? And so me being, the good little therapist that I thought that I was, very sure to bill for a standardized test within this rather than maybe finding a different way using 92523 or whatever. She was so tired by the end of the evaluation and actually reached out to me and was like, I don't think I'm going to follow up because I was just so tanked. I was so fatigued. I was so zapped after that. She didn't want to come back. And that's not typical. And again, that's an opportunity for me to look at, okay, what could I have done differently? And every situation that you're in is going to be different than this one was. But it's a very reflective, it provokes the need for reflection for me to think about what could I have done differently and seeing that maybe I got too involved with the procedure than the actual outcomes that matter and that were important to her.
Yeah. Well, I think it takes courage to be able to see that and say, hey, they didn't come back. What can I do differently? And especially for someone with a brain injury, it is the testing experience. It can be so stressful. It can be so fatiguing, right? You don't know what they have for the rest of their day. Maybe that test wasn't just tiring and they got in their car and they perked up again. Maybe it really set them back significantly. So there's definitely that patient population too, where you might say, is this a good day to test? Do we feel like testing is the right move? And making that shared decision together, I think, certainly very important.
Yeah, absolutely. You touched on this earlier, but the idea of finding metrics things that are measurable, things that represent changes to their life, their actual everyday life, not their life taking a test in your office, but ways to show that and to provide those metrics to insurance companies or to third-party payers or the patients if they're paying out of pocket to demonstrate that there has been improvement. Can you talk a little bit more about those?
Yeah, I think, again, it depends on what matters most to the individual. If it's someone who's very isolated or their symptoms have really prevented them, maybe they're avoiding certain social situations or they're finding that they're doing less. I'm trying to figure out, well, is that important to you? Oh, I just saw an individual, he had a subdural hematoma, again, fell, then bled. He is somebody who for a year, his wife has been doing pretty much everything for him. So when he sat down with me and wanted to think about ways that he could get better, and we sort of talked about, well, what's your day-to-day life like? His wife had really, I think probably necessarily had taken away a lot of things. So even just saying, well, do you want to start these? Do you want to start to participate in them? Sometimes people will tell you, their symptoms, especially things like fatigue, like you mentioned, or headache over, sensory stimulation, that those are things that are so bothersome to them. Your goal might be actually to reduce that through strategies. So I have a woman who works, I'm in the DC area. She works for a government agency with 3 letters. We oftentimes have to be very nebulous about some of these things just because of security. But she works in an office where she cannot bring in devices. She cannot bring in her laptop, her iPad, her phone, right? And she's sitting under fluorescent lights and it's a secure environment. She kind of has to be there until her work is done. And so she's reporting things like pain, fatigue, thirst, because she's not taking time to take a break, right? So for someone like that, you might say, well, what would make it better? Well, how would we know if things were getting better? And a lot of times it was actually reducing symptoms. So thinking about what do we want to maybe take away versus what do we want to add in? What do we want to increase? Thinking about, well, what would that look like? I love phrasing it to that individual when we're setting goals together. How will we know if this is working? And usually they'll give you something that's right on target, or at least you can kind of figure out where they're at. And it is almost never, I always laugh about this because how many goals did I write when I was a clinician in the hospital? 80% accuracy. It's like
Yeah.
no one thinks of life that way, right? They just want to have an improved quality of life with the things that are important to them. So if you can sort of ask, well, how would we know? What would it look like for you? Offer them a couple metrics. Again, I love the self-anchored rating scale, but also a scale of, just on your hand. I have a lot of people with aphasia where sometimes we'll just talk about how easy was that for you? How much did you enjoy it, right? And when they can start to rate themselves in a very accessible scale, then you can start to demonstrate improvement, right? So a gentleman who had a big stroke, who's endorsing that family conversations are like a 1 out of 5, and he has a hand that can easily show those metrics. When we start to build in other language activities, or we're creating opportunities for him to communicate with somebody else, and then he can rate that, a self-reportive improvement is a valid tool of measurement of success. And you can demonstrate, this person maybe was not talking in groups, and now the opportunities he's seeking out. And those are, again, very measurable, but very relatable.
No, absolutely. And it sounds like that's something that takes a great amount of collaboration and creativity because it's going to be unique to the person within their everyday life. I have been working in outpatient setting for, 2 or 3 days a week. I've been seeing a lot of patients recently who have had concussions or have had maybe, measurable brain injuries. One of the biggest things that I've been focusing on that I didn't focus, maybe 10 years ago is cognitive fatigue and like how huge that is. And I'm noticing it in my own life too. As someone who's had, and I mean, we all deal with it, right, to some degree, but as someone who's had in the past, it's more managed now, but, a couple of sleep disorders, and I've had a couple of concussions, and the second one, I didn't know where I was. I didn't know when it was, anything like that. But I see some manifestation of those things. And it's nice to be able to associate like my symptoms during the day. Like I'm having more of them in our pre-conversation because we're doing a podcast at almost 5:30 my time, starting at almost 5:30 my time. And I've noticed that I do a lot better before my cognitive fatigue builds up in the morning. But I guess what I'm saying with that, it is nice for me to have a label and a name for something, one. And two, that helps me to be able to manage things. So within cognitive fatigue, the mental fatigue scale is one that I know of that is also kind of ironic too, because I'll put a link to that in the description of this episode, but the mental fatigue scale it's a measurable self-reported tool that people go through, and it talks about different metrics that relate to cognitive fatigue. The reason why I think it's kind of ironic is because this scale is a beast. I mean, it's like 14, it's 15 questions, I think, 14 at least, that are mandatory, and so many different levels on each question that they're exhausted by the time they're done with it. So it's not something you want to do every session, but it can be very helpful in helping them to realize that they're doing better by not, having more of something, but by having less of something that is, less of cognitive fatigue.
Yeah, I will say, I think I agree with you. That is a beast. And what I will oftentimes do really with any patient-reported outcome measure is, instead of administering the whole thing, if we set a goal around one particular area of concern where the scores are particularly high or low, depending on what it is, I'll just kind of maybe think about that, administering that one item, especially for evaluating how things are going. And I think that helps. It's a creative use of the tool. The other thing I will say on a cognitive fatigue issue is that it's really hard for people to notice cognitive fatigue. Everyone can relate to being physically tired. Even understanding their own signs of fatigue has been a challenge. So sometimes I'll use like the traffic light scale, which I think is great, where it's like, green, I'm good, I can do all the things, and yellow, I'm starting to get tired. And then red, I really need to cut it short. I need to go take that break. I need to recharge the battery. That yellow is doing a ton of work, right? Because we can be in the yellow and be administering, a test at work, or we can be conducting a podcast in our evening. Like, we can do a lot in the yellow prior to brain injury. But some folks really need something that's a little bit more of a visual scale. One of the things I've done with fatigue in my practice is I've made like a gas gauge where we have multiple points along the way. So it's not just like half a tank, empty tank, but we'll say, what do you look like at 3/4 of a tank, or, a quarter of a tank, so that people can start to pick it out, and then also elicit input from family. So, someone might not necessarily recognize when they are just starting to become fatigued. or maybe fatigue is starting to influence. But if someone else can say, you know what, I kind of noticed that you're stumbling over your words, or that you might have to read something again and again. So people can sort of start to understand fatigue. And when they can understand it, then they can start to monitor for it. And then hopefully build in things like brain breaks, or, choosing a different level complexity task so that they have enough to get it done. That's a huge opportunity. There are lots of clients where we spend a lot of time just trying to understand it together.
Yeah, no, that's huge. And I love how you've incorporated different things there. You've incorporated self-monitoring and self-reflection. So they have this kind of barometer throughout the day, but also helping them to recognize what something looks like that they may not have recognized before. So like, I give myself as an example. I didn't always know, like, well, why is my brain so freaking tired? And why am I so inarticulate after, not getting a good night's sleep? And it's going to be different variables that affect different people in different ways. But it's nice because that then puts me in the driver's seat to some degree, where I have strategies. And so with our patients, if they're able to say, maybe a 5 is the worst, I'm zapped and I've got to go to bed, or I've got to, go somewhere in a dark room and just meditate for a while. And a 1's like, I could do this all day. For them to recognize when they're getting to a point where or maybe a point of no return, they're seeing the signs of fatigue, to be able to stop and take a break, and so that they can keep going. One of the times, this is something I have a really hard time with. I love getting on here and talking with people about different things. And sometimes, don't tell anybody, but sometimes I talk too much because I get really excited and I'm like, yes, that makes so much sense. And so I'm recognizing that right now. I'm going to turn it back over to you, because this is just so interesting to me. It is so interesting to me.
It's a good back and forth conversation.
Yeah.
I think one of the things too, especially for individuals who are maybe like more on the higher functioning scale, so you might see someone with a mild TBI, right? Or maybe someone who had a stroke, but like they're very functional, they're able to drive and they can maybe work. Really being able to give that message that everybody, but especially when you've had an injury to the brain, everybody deserves a chance to rest, and prioritizing rest and letting people know that it's okay to take a break during your workday. It's okay to, push back from your computer and stare out the window, or do a really quick mindfulness. I do a lot of coaching with clients on how to have accessible mindfulness moments so they can feel like this is how I rest, or this is how I can take care of my brain during my task demand. And that it's okay for them to say no. And it's okay for them to adjust their own expectations for themselves. Like, so much of that is a lot of counseling, right? But when you see someone who's kind of pushing themselves past their limits and they're taking on too much and they're saying a lot of should, or I just need to do this, when you're noticing that language, you can say, I'm really curious as to why you think you need to do all of this, right? What is the push? Sometimes there are a lot of, competing interests, and people feel compelled, especially if they've just gotten back to work after a, prolonged medical event. They do feel the burden, but being able to say your brain will do better when we can learn the really valuable ways to get it to rest and let it work at its capacity. And that is really, for those brain injured individuals, that is a lot of what we do in therapy.
Yeah, no, that makes a lot of sense. So sometimes the more you push, the less you get, versus just recognizing I need a break and then I'll be able to do more. If I pace myself, try running a mile at full speed and you're going to not do too well. You'd be coughing and hacking and totally out of breath, versus, you jog or you run and take a break. You pace yourself and allow yourself to go at an intensity level that's realistic and proportional to your abilities. So
I love the 4 Ps strategy. Do you know that one?
I don't know that I do. Wait.
The 4 Ps. It kind of bundles them all up. It's pacing, which you just said, pacing, prioritizing, planning, and positioning. And it's really comes from like energy conservation technique, but when you use it for cognitive abilities, it's really nice to be able to say, okay, so you need to pay your bills, or you need to write this report, or you need to do your therapy homework. How can you pace yourself, right? What does pacing look like? And so even having like a task timer or a playlist with music that has, songs that are, 3 to 4 minutes long. It's trying to get really engage an individual to help them to figure out how they can do a little bit and stop, prioritizing, making a list, and then really saying, well, 50% of this has to go. What are you going to do now? So really helping people to understand that the way that they manage their time and their activities needs to look a little different, but that's a very structured way to give them some tools so that they can do that.
I love that. That's really good. That's really good. There are two other things that I want to touch on just briefly. Are there any myths, and, anchoring on one that we talked about earlier, that you think really hinders progress, or even therapists trying to try to make progress with patients?
Yes. I think the myth that, again, perpetuated by SLPs, probably not so much, but definitely maybe some medical professionals who don't have the latest science in front of them, is this idea that neuroplasticity, the brain's ability to change, is time bound. So that maybe it's 6 months or it's 12 months, and then, everything kind of stops. I do so much unteaching of that idea with patients and families, many of whom are frantic because if they've been out of rehab and they've been home and they're in the community and maybe they haven't really gotten to be able to get to therapy, it's almost like they feel like the clock is ticking down and, oh my God, if we don't get this in right now, like what will happen? And so I think the idea, and, I do some work with the National Aphasia Association. I lead a group of parents. So these are people who are younger, who are raising children, and they have aphasia. So maybe they've had a brain injury or they've had a stroke. And there's a woman there who is a dynamo. She had a stroke 11 years ago, and she's raising her son, who's now a teenager. He's a young teenager. And she keeps a notebook of every improvement she's made along the way. And I tell her story to everybody who's coming at me with this 6 to 12 months timeline, because it's like, it's just not true.
Oh, that's great.
And so if you can turn your life into therapeutic opportunities, not to say you have to always be in skilled therapy, because obviously there's resource considerations for that. But if you can look at, here's your toolkit of strategies, here are the ways you can practice, here are the things you really love to do, and let's help you to build out a practice program. Man, like lots and lots and lots of practice to improve. And people can, I think they take great comfort in knowing that neuroplasticity is really up to you. And so as long as you kind of teach them the principles, saliency, repetition, things like that, I think that when they see it and they can apply it to their lives, they feel that there is far more hope than when they came in with that myth that they picked up along the way.
No, that is fantastic. And one of the things that I think is so great that comes from that is putting patients more in the driver's seat to do a lot of these therapeutic activities or reflection outside of the session. Because realistically, I mean, if we're talking about a third-party payer, how many sessions are we going to get on average for most people? Not enough is the answer. And so if we're focusing on helping them to learn things that they can do at home and to record how well they did it, or to rate themselves, to keep a journal of different things, then they can, in a sense, become their own therapist to some degree, right? They can advance their improvement for a long period of time, and they can be also more mindful of the progress that they're making too. That's great. And I appreciate you sharing.
Well, I have another myth, and this speaks to the hospital rehab clinician that I once was, which is that when I was working in inpatient rehab and someone came in with a diagnosis of dementia, no matter what their clinical presentation was, I was so quick to write them off and say, they really don't have any capacity to learn, and let's just get them out of here as soon as we can. And I think that working in the community with someone who has an earlier diagnosis, let's say mild cognitive impairment, or maybe a newer diagnosis of dementia, to really have faith that those individuals for a time can really benefit from skilled interventions. They can use strategies, they can pursue learning opportunities, they can seek out connection. I think that was one of the biggest myths that I disproved as I started to be in that community, and that there's value in their educational pursuits or value in their daily moments. And it's our job to facilitate that, to delay the decline as much as we can. So that's another, I would say, clinical population that I do work with. And I really feel like I have been able to reframe my own thinking on that.
I think I agree with you. And it's been really hard for you not to tangent on the book in your background. The second one up, called Dementia. That's Michelle Bourgeois.
That's Michelle Bourgeois, yeah.
Yeah. Mm-hmm. She had a really tremendous influence on me as an early clinician when I was doing actually some clinical instruction at the University of South Florida, where she was. She really emphasized the idea of moving beyond impairment-based therapy and doing things that are manifestations of cognitive disability or whatever you want to call it within the person's everyday life. And so that's one thing. But the other thing too is she would see patients who had dementia. And whenever I was in my externship and we had a patient with dementia, the therapist said, I don't work with dementia. We're not going to see them. Like same sort of thing that you mentioned.
Mm-hmm.
But it takes a reframing of this is beyond fixing people. This is beyond getting them to have a higher level of accuracy. Because if you frame it that way, well, yeah, they're going to decline over time. But what can you do? You can use external memory strategies. You can help them to be more efficient with their memory with internal memory strategies. With the external ones, use a calendar, use a checklist, a to-do list, learn how to prioritize things on the basis of the impact that they'll have, this task, this work you have to do will have in your life versus the effort you put into it. Like there's a lot of ways that you can work with individuals, and it might not be 10 sessions. It might be like 3 sessions, and it might be a lot of collaboration with the family members. Mm-hmm. It depends, but there's so much more that I think we have written off because we might see therapy the wrong way and see it purely as a fixing mentality.
Well stated. Absolutely.
Yeah.
I have a woman I'm working with now who she's in assisted living. Her daughter is there all the time in our sessions, and we are working on a photo-based memory book. And when I found photos of, her family, and again, large font, taking a lot of principles from that book, large font, simplified language. Mm-hmm. And I was able to show the daughter how instead of constantly trying to correct her when she's getting a fact wrong or a name wrong or a relation wrong, we can put this in front of her, have her read it out loud, which is a very well-preserved skill. And she just lights up and the daughter's less stressed. It's like, wow, what a benefit, right? I mean, I wouldn't do that therapy for 6 months or 2 years, right? It's like you said, it's kind of time limited, but the benefit to the family, the benefit to the people who are at the assisted living caring for her, when you can create really meaningful visual cognitive supports and you can change someone's cueing style. Amazing. Amazing.
Yeah. Very good. Very good. So one last thing that I want to touch on before we split up here is the name of the podcast is Swallow the Gap. And almost said dug my own coffin. There's my cognitive fatigue. Almost dug my own grave, naming it Swallow the Gap, because it's like, it have to be about swallowing all the time. And obviously this episode has not been about swallowing very much at all. And this is, broadly can be a medically focused speech pathology podcast. But for this in particular, what are some of the ways that cognitive therapy and dysphagia therapy might overlap in your experience?
I think this is one of those situations where thinking back, or even meeting some people who are maybe really into dysphagia, and they're like, I only treat dysphagia, I don't treat cognition. And I think about the fact that every strategy you have to train, every piece of education that you have to educate on, everything you hope to set up in a home practice program requires cognition. And so one of the things I think for that clinician who's really siloed themselves is to say, why are you not thinking about cognition as a part of what you're doing, even indirectly, right? So maybe cognition's not the direct target. Let's say it's, dysphagia. Do you feel confident to speak to cognitive concepts like working memory or prospective memory, right? Or attention or complex attention. So these cognitive domains to me they're really valuable. I think they're certainly valuable for the clinician to understand, well, how am I going to get this information to this patient, right? Because training someone to swallow differently or helping them to understand maybe some of the IDSI, diet texture levels, it takes a good amount of cognition, right? To be able to learn new information, to be able to retain it in their mind and be able to demonstrate it either through behavior or through verbal knowledge. All of that is cognitive communication. So I think for that clinician who's really sort of thinking very specifically, very focally, just appreciate what are you doing differently from one person to the next to help to be successful with your therapeutic interventions. And it's probably, you're not necessarily changing your dysphagia techniques. Those might be pretty standard, but it's probably how you're delivering that therapy. And so I'm a huge proponent of things like learning about active listening, changing your own communication, offering pauses and a chance for someone to kind of recap or redemonstrate something to you. That's really cognitive therapy. You may not call it that, you may not bill for that, but that's what that is. And so I think one of the things I'm working on is some continuing education for really clinicians, not just SLPs, but OTs and PTs, about really understanding cognition, how to talk about cognition, how to see cognition in everyday rehab. I think that's an opportunity for a lot of folks. And I hope to improve the knowledge base of the rehab world in that way, because I think when you start to see it, then you can kind of troubleshoot, well, if something's not going right, what can I do to change it? How can I make sure that this therapy is as successful as possible? And cognition is probably a part of that.
Very cool. Very interesting. Thank you for that. Yeah. Just to kind of help to say one more thing before we wrap things up. Earlier, I mentioned kind of reframing cognitive therapy beyond just improvement and beyond just, a better test score and something to that degree. And I think that really parallels to what we're talking about, how we integrate cognitive intervention, whether or not it's purely focused on that or even build that way within our dysphagia therapy. We have to reframe how we look at dysphagia as well, or how we look at our intervention with that. So not everybody that we see is going to be appropriate for a certain number of exercises or even rehabilitative therapy, so to speak. Typically, at least within my therapy, if it is rehabilitative, there's still, for a period of time, at least there will be a compensatory component to that. There's one individual that I'm thinking of who really is to the far side of the compensatory strategy spectrum. He was an older individual who was a trumpet player, some sort of horn player in the past, and he had this huge pharyngeal diverticulum. He had this pouch in his pharynx that would catch the food or liquid, and then he would aspirate it from that. And so, there's a lot to be said for that in terms of what can be done. But basically, he was old enough and his goals were such that he didn't want to have surgery, right? I'm not going to fix that with the effortful swallow. And if I try to do expiratory muscle strength training, I'm probably going to make it worse because I'm going to increase those pharyngeal pressures that I don't need to do, right? And so I'm not going to fix it with some swallowing exercises. And he doesn't want to have surgery. So is he just left to kind of, suffer through this? One of the things that helped was a head turn to the side of the diverticulum because, it's going to close off that side more and it's going to use the other side that doesn't have that physiological or anatomical impairment there, right? And so say if he was an individual who maybe had issues with memory too, how are we going to help him to remember to do that strategy? So with that compensatory strategy or any number of others, how do we get them to remember that? Is it going to be involve helping caregivers, to provide the support that somebody needs? Is it going to be an external memory strategy? Will it maybe be spaced retrieval training? Because they're at such I hate to say lower level. There's a better way to put that, but at a level of impairment where maybe they need something like spaced retrieval training for one specific thing. They just need to do that one thing, and that's going to have the biggest impact on their quality of life. And so that's just a story that I thought of that your spin on this really resonated with. But anyway, I know we've covered a kind of a lot of different ground, and I made my feeble attempt to kind of circle this back around to dysphagia. It
was perfect. It was perfect.
I appreciate you bearing with me for that. Before we go, is there anything else that you would really just like to leave with people? You've already left so much, but is there anything else that you'd like to throw on there as a cherry on top?
Yeah, I would just say, I think one of the best parts about our field, and I think this is a challenging time in the world, but also in our field, certainly the best part, I think, is being able to pivot to a different version of practice. And I never, ever thought I would be where I am sitting right now. I really was a hospital clinician, true and true. I really thought I would be there forever. And when I kind of looked up and was able to broaden my horizons about what professional life looked like, I stumbled into this, created this version of practice. And I'm so satisfied, like you said. I find this work so rewarding. I'm invigorated. So I just think for people who are maybe feeling burnout or hospital life is getting hard or they're not really sure how to do it, I think that finding private practice has been just a highlight for me that I just never expected. And so I think being flexible, knowing that some people need to walk away and we get that, but also to think about what else can I do? How could I do this differently? what other space could I be in that might, speak to who I am as a clinician, that it is possible. And I'm sort of living that life. So if anyone's curious about that, I'd be happy to share more thoughts on it. I think that, mentoring clinicians who are really struggling is a big piece of why I think these podcasts are wonderful, but also clinicians with experience can really share with those coming behind us.
Wonderful. Well, I will chat with you after we're done recording to see what your preferred method of contact is, and we can put that in the episode description so that people can reach out. I feel very strongly that there will be some people who reach out because I felt that way, and I've talked to so many other clinicians who have felt that way too. They kind of feel like they're in a dry spell and they're not really, or they're on autopilot and they're not really enjoying what they're doing as much anymore. So I appreciate that you're a testament to how to get out of that funk. And so thank you for that as well.
Happy to help. Absolutely. Thank you.
Yeah. Well, thank you so much, everybody. Lauren Schwabish. Appreciate you coming on the air with me, and look forward to seeing you in the future and chatting.
You too.
Thank you for listening. If today's conversation sparked questions or thoughts, please check out the show notes for Lauren's contact information in the resource we mentioned, the Mental Fatigue Scale. If you have ideas for topics or for speakers that you'd like to see a course or a webinar on, let us know at swallowthegap.com/poll. That's swallowthegap.com/POLL. And on a different subject, there's a head and neck cancer webinar coming up in late January, and you can find more details on this at swallowthegap.com and go to the courses portion of the page. Thanks again for listening. We appreciate you spending this time with us, and I hope to see you next time.